Good afternoon, everyone, and welcome to the third and final, at least for now, listening session to gather community input and feedback on the Innovation Partnership Fund. My name is Melissa Martin Millard, and I'm honored to welcome you to today's session. Thank you so much for your willingness to participate and share your insights. Your engagement is essential to shaping thoughtful, responsive, and forward-thinking strategies that will strengthen the Innovation Partnership Fund programmatic efforts. Just by way of some history and background, we, the Commission, launched our listening and learning efforts last fall and have continued those efforts throughout the spring and summer. We've had conversations with county leaders, with community-based organizations, people with lived experience, and our state partners, as well as those of you from the community who've attended our listening sessions. Today's session marks the last listening session dedicated to hearing from a wide range of community partners. Our next steps will be to hold a program advisory committee meeting on September 18th, where we will share out the findings from our engagement efforts and share an initial framework for how the Innovation Partnership Fund will operate. We will then have the Innovation Partnership Fund as an agenda item at our full commission meeting scheduled in October. Right now, I'd like to acknowledge the presence of our Commissioner, Mata Madrigal-Weiss. She is here in her official capacity as Vice Chair of the Program Advisory Committee. And then in the last 45 minutes or hour of our time together, we will be joined by Commissioner Gary Tsai, who is Chair of our Program Advisory Committee. So welcome, Commissioner Madrigal-Weiss. And then one housekeeping item before I turn it over to our facilitator. We, based on feedback that we got from participants from prior listening sessions, we have enabled the chat function, and I see that a couple people have already introduced themselves via chat, which is great. We've also enabled the Q&A functionality. So you can make comments and ask questions through both of those channels. However, we do encourage, if you have a statement to make or input, we encourage you to provide that verbally. We really want to make sure that we're having a dialogue and that everyone is able to hear your input and feedback. That said, I will be monitoring the chat and the Q&A. And we'll try to address questions and comments as they come in and lift up any questions or comments to the larger group that I think we might want to hear collectively. Depending on the volume, I might not be able to verbally address every comment or every question, but I'll do my best to be responsive, and we will be taking in all the information that comes in through the chat and the Q&A and incorporating it into our summary and analysis. So with that, welcome. And I'm now going to turn it over to Sarah Brooks, Senior Director at Sellers Dorsey, to facilitate our discussion on the Innovation Partnership Fund. So Sarah, I will now pass it over to you.
Thanks, Melissa. Good afternoon, everyone. As Melissa said, my name is Sarah Brooks. I'm a Senior Director with Sellers Dorsey. We'll go ahead and walk through the slides. We're excited to be here with you today and talk a little bit about the Innovation Partnership Fund. All right, next slide, please. So a little bit of background to start about the Innovation Partnership Fund. It was created by Proposition 1, which passed in March of 2024. It does revamp the Mental Health Services Act, MHSA, into the Behavioral Health Services Act, which is now the BHSA. The IPF is administered by the Commission for Behavioral Health starting July 1 of 2026. It'll be $20 million a year from fiscal year 2026 to 2027 through fiscal year 2030. Sorry, I can't talk today. through fiscal year 2030 through 2031. So $100 million total. So just to break that down, it's 5 years, $100 million total, $20 million a year. Next slide, please. So a little bit of information just about what we're going to be talking about today and what we won't be addressing today. So areas for today's discussion are highlighted in purple on this slide here today. We'll clarify the vision and goals. We'll define the investment pillars. We'll talk about the fund structure and types of support. Some of the things that we won't get into today are the nuts and bolts: governance and decision-making, capacity building and technical assistance, data metrics and outcomes, financial sustainability and policy change, and communications and storytelling. Those will be dealt with in future discussions. Next slide, please. Melissa did a really good job of walking through kind of the timeline and where we've been and next steps, so won't go into too much detail here, but this slide outlines the progression of what's happened with the Innovation Partnership Fund to date and where we're going. So as you can see, we've had the 3 different listening sessions. We're here today in September. It is September, yes. In the virtual community engagement session that's presented here on the slide. And as Melissa said, we'll go into the PAC committee meeting next, and then present at the commission meeting in October. Next slide, please. So just a little bit of background about how we got here today. We've had a number of different discussions with individuals in the community. We've collected information through these listening sessions. We've talked with advisors. And we've gathered information as to kind of what should be considered when we think about the IPF. And we were able to gather some relevant terms and detailed information from you all that we thought was significant and important to bring to the light. And so wanted to just kind of label those terms here for you all. Community-centered was one that really popped for us, so we put that right in the middle here and highlighted it for you all. But there are other kind of key and important terms that are on the slide here that you all made sure to point out to us that we agreed with. Language access, integrate systems, transparency, technology, urgency. You can see there are a number of different terms that are kind of included here that should be considered for purposes of the IPF. Next slide, please. So we'll talk a little bit about the Innovation Partnership Fund purpose and target population. The one thing I want to kind of hone in on here that's on the slide here is defined in statute, no feedback needed. So I think the red that's on the slide here, what's key here is that this has already been defined in statute. So we'll present this today. Definitely have an opportunity to see if there are any questions about the information that's presented, and see if there's any need for dialogue, but just defining the fact that, or just ensuring the fact that it's clear that this language here is defined already in statute, and so no changes can be made to it at this time. Next slide, please.
Hey, Sarah, I was going to say,
Yes.
can we go back just a couple slides, just to that
Yes.
one slide, so we're making sure that we really, really emphasize what we're talking about here today?
Yes, go ahead, Brenda. Sorry about that. If
No,
I
that's
missed
okay. That's
something.
okay. And I was gonna say, Commissioner Madrigal-Weiss, feel free to jump in as well. But just
Yeah,
wanting to
please
say,
do.
just because it might frame it a little for this group that you know, in terms of what we are able to talk, we're really looking to clarify the vision and goals and define the investment pillars and fund the structure and types of support, as Sarah mentioned. The nuts and bolts, so these other pieces are not things that we're talking about here today, but that are going to be included as important components within our grant project and our program. So again, just want to make that really clear, you know, to just emphasize that, you know, that basically these items are really important, and they all kind of go together, but really just wanting to make sure that that we're really focusing in on what we're like the big picture items. Mata, if you do want to say a little bit more, just to make sure that we're capturing everything.
Yeah, no, I appreciate it. I think where we want to hear from our community is these big picture items, right? The vision, the goals, and the investment of the pillars, and then the nuts and bolts. The staff will continue to be working on that with Brenda's leadership and guidance, along with Commissioner Sy, because those will be the details that will shape everything as we put it out there, but we want the expertise of our community to really help us clarify that vision and goal. So thank you so much, Brenda, for
Yeah,
lifting that up.
and just kind of saying, and we're leaning also with the Sellers Dorsey team is kind of helping us with that. And so as Melissa had mentioned, when we go to the program advisory committee meeting and then to the October meeting for the full commission meeting is when we'll continue kind of building out those ideas for the nuts and bolts and getting stakeholder feedback on those items as well. So anyway, sorry, just wanted to emphasize that a little bit more. Sorry, Sarah,
Yeah.
thanks for
No,
letting us talk
excellent.
just a little bit longer for that one. So
Perfect. Thank you,
Thank
Brenda
you.
and Commissioner Madrigal. That was wonderful. Thank you. I think wonderful. Perfect to emphasize that and make sure we're clear on kind of purpose of today. All right, so circling back to kind of purpose and target population, we'll go to the next slide. The IPF has two elements. The first element, including that are presented on the two slides here that we'll walk through here for you all. The first element with respect to the IPF states that the IPF shall be designed for the following: to improve BHSA programs and practices funded pursuant to W&I Code 5892A for the following groups: underserved populations, low-income populations, communities impacted by other behavioral health disparities, and other populations as determined by the BHS Oversight and Accountability Commission. So that is the first element. The second element, which is presented on the next slide, states that the meeting statewide BHSA goals and objectives. So within Proposition 1, statewide BHSA goals and objectives or measures are discussed within the context of the county integrated plans. These plans are these statewide BHSA goals and outcome measures, which must include goals and outcome measures to reduce identified disparities, are as established and defined by DHCS, the Department of Healthcare Services, in consultation with the Commission, counties, and stakeholders. If you're looking for more information regarding these DHCS established statewide BHSA goals and objectives, you may find it on their website or the DHCS website in the BHSA policy manual, which is linked on this slide here. So additional information about these metrics and outcomes can be found there. All right, next slide, please. With respect to kind of the BHSA programs and practices, the IPF focus as outlined in WIC 5892A outlines the focus for county programs and practices as follows. Housing intervention programs, full service partnership programs for the chronically homeless, for capital development projects as specified, full service partnership programs as specified, and then for the following behavioral health services and supports: services for the children's system of care and the adult and older adult system of care, early intervention programs as specified, outreach and engagement, workforce education and training, capital facilities and technological needs, and innovative behavioral health pilots and projects. All right, next slide, please. And then target populations. So the slide here outlines the target populations that the IPF will focus on. So eligible children and youth who satisfy one of the following: those who are chronically homeless or experiencing homelessness or at risk of homelessness, are in or at risk of being in the juvenile justice system, are re-entering the community from a youth correctional facility, are in the child welfare system, or at risk of institutionalization. Eligible adults and older adults who satisfy one of the following: are chronically homeless or experiencing homelessness or at risk of homelessness, are in or at risk of being in the justice system, are re-entering the community from state prison or county jail, are at risk of conservatorship, or at risk of institutionalization. So again, these are all kind of different target populations that can be considered for purposes of the IPF, and they stand alone respectively. All right, next slide, please. So in sum, Proposition 1 funding, and specifically IPF, must be directed toward those populations with the highest behavioral health needs who often face structural barriers. So wanted to just pause here now and see if there are any questions, comments. There may have been something in the chat that I may have missed. Melissa may pull that through. Just wanted to pause and see if there was anything that the participants might want to ask today in follow-up to this section of the presentation.
At this point, if you would like to make a comment, please use the raised hand icon, and I will be happy to call on you in the order that you raise your hand. Thank you. Okay, we have a comment. I'm going to go, Josephine, I'm going to ask you to unmute, and you should be able to speak now. Thank you.
Thank you. I just had a question about the second bullet here. I see that it says that the provisions provide a clear statutory mandate, but I'm wondering if the legislation itself specifically or explicitly states the underlined sentence following the word mandate.
As in a direct quote, Josefina?
Yes.
I don't think that's a direct quote, but I think we have Chris Soggy on with us today. Who helped us with that? Oh,
Sorry, apologies. Could you repeat the question?
just the second bullet on the slide where it says Prop 1 funding and specifically IPF must be directed toward, that's not a direct quote from the statute, right?
Correct, that is not. The one above it is.
Great. Thank you.
Thank you so much. I am going to go to Carlene.
Hi, I have a question under the adults and older adults. And so I think the last two bullets were at risk of conservatorship and at risk of institutionalization. And I'm wondering who would be the determinant of that?
So I think your question is an excellent question. So I think what you're asking is who would make a determination as to whether or not an application would consider a population to fall into one of those categories? Is that what your question is?
Yes.
Okay, thank you for clarifying that.
And specifically for older adults that I'm defining as maybe 55, even though the state sometimes does 60.
Okay, thank you for clarifying your question. So Brenda, correct me if I'm wrong, but there will be an application process and that will be defined through the application process. Is that correct?
Yep, and this is just exactly how it's written in the statute, Carlene, like exactly how it appears in the statute. So, and in terms of at risk of, it would be probably an applicant saying that they would be serving or seeking to serve individuals who would meet these priority population definitions.
Okay, our next question is from Steve. Steve, you should be able to unmute yourself.
Yeah, on this, it says behavioral health needs who often face structural barriers. Can we talk about how's that, I don't know, definition of that?
Like access to services and, trying to navigate systems. I don't think we actually have a real, it's more just like people who are struggling and trying to navigate or access behavioral health or healthcare services that they need.
Because, for veterans, many times, the stigma associated with seeking access to care but that's, structural, I'm thinking like things that are built in, but you know what I mean? So I'm talking about stigma and how does that, or does that fall under that? I'm just trying to thinking around
Yeah,
it.
well, it's good that you're even raising that as it's just people who are, the whole point of this is just that there's populations that are struggling and getting the care and supports that they need to live and thrive in our communities. And so really that's what I say spirit of what that sentence is trying to say. So, but it's not like a legal or explicit thing, but that's what we're trying to convey is that basically these are folks who are really having a hard time getting care.
Right, okay,
Yep.
thank you.
But thanks for flagging that, Steve, in terms of language and stuff. So, because it's not just necessarily structural, but it could be stigma that is impacting people from navigating or getting access to care.
And Camelia, you are our next comment. You should be able to unmute yourself.
Thank you so much. Hi, Camelia Mordazadeh. Yes, my question is actually building off of the prior one, but I think I was curious of how, if there is efforts to kind of think about that language of initiatives that are also working to increase access and by way of, for example, reducing stigma or working on, kind of community-centered or community voices that we think about talking about the mental health challenges or things like that. I'm curious, like, if there's opportunities to kind of think about that more expansively.
Sorry, I couldn't get off mute there. I think, yeah, I think certainly, as Brenda kind of indicated, the thinking here is that we would be thinking in a kind of broad way to include those who have, I mean, I think it's more broad in terms of just including the language, those who have often faced structural barriers. So, I mean, Brenda, it would be more inclusive from my perspective. I don't know if you would disagree with that.
Yeah, no, and Camilla, I was trying to get, or is it Camelia? Sorry. So was it that you're trying to think about different strategies to serve population? It was almost kind of sounding population healthish kind of for a second. So
Yeah. Yeah. And I think that's what I kind of want to understand a bit more too, because I think if it's an initiative that is thinking about, increasing access or removing barriers, but doing it through, thinking about community voices and kind of how we talk about, say, stigma. Is that something that is considered? And that's kind of, again, just kind of to that point of like we say, structural barriers, knowing that those oftentimes come also from things that people have experienced or conversations or historical disparities, and kind of if we can think about initiatives that also try to change those conversations and perceptions of services.
So what I hear you saying is that one of your recommendations for structuring this grant is to think about projects that would address those very needs,
Yes.
which I think kind of goes into, if we went back a couple of slides and it's saying like, we're trying to target low income, disturbed populations. Like, yeah, if we go back just a couple more things, there we go. So, it's like, I would envision probably proposals that would address a lot of this, and that
Yes.
what you're explaining would be kind of required or necessary to be able to target these populations to address some of those disparities in terms of stigma and such. And really, I think that ultimately 90% of the money that for BHSA goes to the counties to implement the programs for the priority populations. And so IPF, or the innovation projects, are really seeking to come up with ideas or innovative approaches to help counties do that work. So, so I think,
Perfect.
so
Okay.
I
No,
hear
that
a
actually is,
recommendation
yeah.
of what you're saying, but then, and then also just helping everybody just to kind of think about like, what could those projects be that really address these issues to really remove the structural or stigma type barriers to be able to reach these populations.
Yeah, that actually makes perfect sense. And you recapped it. And I like it
Awesome.
framed as a recommendation. So thank you so much.
Of course. Thank you.
And Camelia was our last comment on this section.
All right, thanks to everyone for your comments. We appreciate them. Oh, one more hand came up. I think. Am I right about that?
I'm seeing Karen Lim.
Yes, I do have a question, comment. Regarding the target populations, is that for, because the list, there's a pretty severe, it's pretty severe, right? The presentations. Does that include target population for early intervention services as well? Because they sound very much like FSP target population. And I'm curious about that, because if we're hoping to serve the underserved AAPI population, if we go by this list of target population, we're not going to serve very many, honestly, because a lot of them don't, they may not reach this level of severity, but they still need a lot of, early intervention services. So for example, on the target population list, the children and youth are in the child welfare system. But a lot of AAPIs, they may not reach that level, but they are at risk of being the child welfare system. Or they may not be in the, be, how do I say it, at the attention of the child welfare system or DCFS yet, but there's clearly a lot of risk factors.
Sure. So maybe we can flip to the next slide, I think it is, or no, maybe go back a slide. Sorry. So I think this slide demonstrates more broadly that WNI 58928 can be more broad in terms of not just full service partnership programs. And Brenda, you may jump in here and speak a little bit more about this, but it can be more broad. And I think you're talking more about AAPI, but I think that it can be more inclusive and it's not specific to just full service partnership programs. Hopefully that's answering your question. And Brenda may have additional to add here.
I say that it's not just FSPs, it can be early intervention, because counties under BHSA are being required to still continue to do early intervention programs. And the idea is to prevent behavioral health conditions, in particular, like things like serious mental illnesses and or substance use disorders from becoming severe and disabling. And so really that idea is we would want to catch it upstream. I mean, that's what counties are really wanting to do, is catch things upstream to, again, try to get folks on the best path possible in life. And so to the extent that it fits within this, because this is what the counties are being required to do, the purpose of the IPF funds is to try innovative projects that are going to help the counties to implement the Behavioral Health Services Act requirements.
Thanks for that clarifying question, Karen.
And that was our last comment. Oh, we have one more. I'm so sorry. Sorry, everyone. Katrina, your line is unmuted.
Thank you. Tell me if this should wait till later, but what I see time and again is the goal is innovation, but the tolerance for risk is 0. And I don't know if you can speak to that at this moment or if you're addressing it later in the session. But I think one of the biggest challenges for truly innovative things, especially in the field of digital mental health, which is where we operate, is people are too risk adverse to put innovative solutions into play. And I see that both with the adolescent population, and I think the veterans population would be a candidate for that as well.
I think certainly your comments would weigh in on the definition of innovation when we get to that section, which will be coming up in just a couple of sections. And we definitely would welcome your comments at that point.
Great.
Thank you.
Thank you, Katrina. Okay, our last comment, we can move on.
All right. Thanks to everyone for your input there. All right, next slide, please. All right, we're going to talk a little bit about setting priorities. The commission has identified 6 priorities. Next slide, please. For proposed priorities to focus on for alignment with the goals of the Program Advisory Committee. Those are equity, financing and sustainability, public and private partnerships, lived experience and community leadership, alignment with state efforts, demonstrate agility and lean process integration. Brenda or Commissioner Madrigal, I'm not sure if you guys would, either of you would like to speak on these 6 proposed priorities at all.
No, I think we just want to hear from everybody else.
All right.
Commissioner, if there's anything else, but I think that's where we're looking to hear from them.
Okay. All right, so then I think would just want to go to the next slide, please. We proposed a couple of questions here. Do these priority areas resonate with you all? Is there a priority area you would recommend we remove or add? So we'll go back to the priority slide just so that we can hold it up for you guys to be able to see the 6 priority areas that are being proposed. But with the questions being really, do they resonate? Would you remove something? Would you add something? We welcome your feedback and look forward to hearing from you all. Thanks so much.
Thank you all. Our first commenter is Jose. Your line should be unmuted, Jose. Go ahead.
Hi, everybody, and thank you for doing this. I'm 100% equity. Finance and sustainability is like a really huge priority right now with, I believe, a lot of partners, especially non-traditional partners that are actually doing innovative stuff. So I think financing and sustainability is really high on there in the public-private partnerships as well. The lived experiences, I mean, I work in an organization that we really practice that lived experience, and it really helps when we're trying to gain the credibility of the community, especially in the community leadership, because they know that we know how to do stuff sometimes. So yeah, all of this I think aligns perfectly. I would highly recommend that equity is taken into high capacity within all of these. So definitely really appreciate this information. Thank you.
Thanks, Jose.
Thank you, Jose.
Oh, sorry about that.
That's okay. Patty, your line should be unmuted. Go ahead.
Hi, yes, I work with NAMI, and it's the National Alliance on Mental Illness, and our MHSA funding has done just a world of good for us. With the changes, our early intervention programs are pretty much cut out. And my understanding is that especially with mental health, the earlier we can address issues, the more success we have. And so I'm a little concerned that the early intervention portion of the MHSA is so tiny now. So I'd like to add that back in.
Thank you so much, Patty. Josefina, your line should be unmuted. Go ahead and speak.
Thank you so much. I didn't introduce myself before, but I'm Josefina Alvarado Mena, and I'm the CEO of Safe Passages and also representative of the California Reducing Disparities Project. And I really want to uplift the equity priority and also reinforce that when we looked at the priority population slide, both for the youth and for the older adults, that people of color are overrepresented in almost all of those categories. Also, I want to uplift the financing and sustainability priority because often what is missing is infrastructure. And so when we talk about innovation, what frequently happens is that innovation is funded and then dismantled because there is no infrastructure to support sustainability of the innovation. We cannot scale what works. We can usually not scale what the communities are asking for and that what they're saying is effective. So the financing and sustainability is critical. In terms of the public-private partnerships, I want to put a flag in here because I think that one element of this should be that whatever is funded should not be proprietary. And so it's important that the people of California own the innovation here and that if we want counties to take up strategies that are funded and that are proven effective, then we have to make sure that they are able to do that. And when we insert proprietary interests, then that restricts our ability to do that. And I don't think that's a fair use of public funding. And then finally, I would advocate to add a new priority that we counteract what is happening at the federal level. This is a horrible federal context for not just behavioral health and healthcare services and health equity, but for people of color, immigrants, LGBTQ+ communities, and we're really under attack. And I spend every day in my organization trying to counter what's happening now at the federal level. We have the opportunity with this federal funding to counteract what is happening and to protect what we say is important for California. So I would strongly advocate that we add a priority here that addresses counteracting the federal policy changes and the dramatic enforcement and pretty much assault on our principles. Thank you.
Thank you for your comments, Josefina.
Thank you so much. So sorry, just 1 second. So Barami, you should be unmuted. Go ahead and speak. Let me try again. You can try to unmute yourself. Thank you.
ខ្ញុំអាចទៅនិយាយបានណាបាទខ្ញុំអាចនិយាយខ្មែរខ្ញុំខាងខ្មែរ
Oh, I'm gonna.
ខ្ញុំឈ្មោះហុកបូរីនៅសមាគមខ្មែរខ្ញុំឃើញគេមានថាវការអញ្ចឹងខ្ញុំចង់បានឲ្យជួយនៅខាងសមាគមខ្មែរបណ្ដុះបណ្ដាលខាងផ្នែកជំងឺផ្លូវចិត្ត
I know we have our interpreter online.
Yeah,
ព្រោះនៅ
we do
សមា
have
គមខ្មែរខ្ញុំហ្នឹងគឺមានប្រជាជនខ្មែរ
we do have an interpretation
នឹងមិនស្គាល់
available.
មិនទៅយល់ពីជំងឺផ្លូវចិត្តទេព្រោះគាត់នៅផ្ទះតែម្នាក់ឯងជួនកាលអញ្ចឹង
Okay.
Okay.
I was going to
Thank
say,
you
we
so
have our
much,
interpreter
Soberon.
online. I was going to say,
Yes.
Callie, we have our interpreter online. I don't know if they could do on the fly interpretations or we just grab the interpretation.
I'll work with the interpreter and see if we can get Soberon into the correct room.
Okay, thank you.
Thank you so much. And I do believe that's our last comment for this section.
Thanks, Callie, and thanks to everyone for your input in this section. We have appreciated it. All right, we will move on to the next section, which has to do with innovation and the definition of innovation. So we have put together a proposed definition for innovation, which has been placed on the slide here for consideration. Innovation would be defined as a new or adapted approach to solving persistent problems in California's behavioral health system, especially those that relate to equity, access, workforce shortages, and service fragmentation. So I just want to kind of outline how we consider the bullets that are presented on the slide here. They are standalone bullets, though there is an and here, and I think we keep forgetting to update the and to or. These bullets are standalone bullets. They do not work together, so they should be considered separately. To be considered innovative under this fund, a project must be included in one of the 4 bullets that I'll just run through real quickly here with you. They must advance new models, tools, partnerships, or technologies not yet widely implemented in California, which may include adopting or scaling efforts underway in one county, but that could be scaled in other counties. The project must introduce or scale practical community-centered solutions, including community-defined evidence-based practices that increase access to prevention, treatment, and recovery supports, particularly for historically underserved populations and inclusive of harm reduction approaches. The project must demonstrate a clear break from the status quo, not simply incremental improvements to existing programs or efforts, but a concerted deviation from those efforts. Or the project must be actionable and ready for real-world implementation, not solely focused on concepts, research, or pilot testing. So in a nutshell, innovation may include ideas from other sectors or geographies, adaptation of promising practices, or bold new models co-created with people with lived experience. At its core, innovation is about transforming how we deliver care with impact, equity, and dignity. So again, we'd like to ask for your feedback as to the definition here that's been presented. Does this definition resonate with you? What would you change about this definition? So we're going to open it up for dialogue now. Welcome your questions, your input. I see hands have gone up already. We look forward to hearing from you all.
Mr. Hook, I'm going to unmute you and I'm going to try to get you in the correct room if you still need assistance. Okay, I think Mr. Hook's hand is just up. I think we don't have any other comments at this time that I can see. Please. Oh, no, we do. Josefina's got a hand up. Just a moment. Josefina, you should be unmuted.
Thank you so much again for this opportunity. I just want to uplift community-defined evidence-based practices here. I'm really excited to see you know, the second bullet and the specific reference to community-defined evidence-based practices, I think this body of work, which we have been implementing and piloting and evaluating as part of the California Reducing Disparities Project, has shown tremendous promise in terms of closing the gap in behavioral health equity across the 5 target populations, but also across the age continuum. But one thing that I don't see strongly referenced here is effectiveness. And so I think that the definition needs to include some language related to demonstrating effectiveness. So that's one element that I did want to ask about. Thank you.
Thank you so much, Josefina. Elizabeth, you are our next commenter. You should have your line open. You can unmute yourself.
Thank you. So agree with Josefina about making sure that there's some kind of measures about how these programs are doing, and then also wanted to highlight what's happening in the chat about thinking of innovation funding as a way to help with prevention and early intervention programming, and it could be from an innovation perspective, so new ways for prevention and early intervention, but prioritizing those type of programs for funding just because of the funding cuts happening, and acknowledging that a lot of these programs in place today under the PEI and MHSA do go to support BIPOC communities, so Black, Indigenous, and people of color. So making sure that those populations continue to be served in the way that they have been entrusted to be served through the community partnerships that are in place today. Thank you.
Thank you so much, Elizabeth. Erin, your line should be unmuted.
Yes, yeah, I just wanted to agree and support Josefina's comment about the definition of innovation. I think it would look good to have something to include in the clarity that there's results-driven data in these programs, whether it's a partnership or I'm in technology, so like that, I think that would be very helpful, because I feel like this definition is a little broad.
Thank you, Erin. Alan, just 1 second. Alan, your line should be unmuted. Go ahead.
Right. Well, thank you so much. I also agree with the previous comments said, and I also just want to say that in the second bullet point, it says increase access to prevention, treatment, and recovery supports. I wanted to highlight the prevention portion, and also because through prevention, it means like they don't have any substantial factors just yet. All we're trying to do is prevent. But in the population served, it's kind of contradicting because it says eligible children are chronically homeless, at risk of being in the juvenile system. So there's not much prevention going on there for the population served. So maybe being able to modify that to also include prevention within that topic.
Thank you so much, Alan. Mia, your line should be unmuted. Go ahead.
Hello, thanks for the opportunity to give feedback. I'm Mia Cooper-Kahn. I'm with Alameda Health Consortium, the network of 8 federally qualified health centers in Alameda County. I just wanted to echo some of the comments around including prevention and particularly emphasizing early intervention as part of the eligible programs. At least in Alameda County, we're seeing that even though under BHSA, counties still have early intervention funding, that CBOs and agencies are having to become part of the specialty mental health system and contract with specialty mental health, which isn't feasible for all especially smaller CBOs. So having this IPF be able to cover continue some of the funding that has supported these community-based early intervention programs under MHSA, I think is really important. So making sure that's reflected in the definitions and the criteria, I think is really important. Thank you.
Thank you, Mia. Katrina, you should have your line unmuted now. Thanks.
So I want to put an exclamation point after Alan's comment that when you get to juvie or child welfare or some of the other things that I can't, refer back to quickly enough on your deck, that's when children or families are in crisis, and prevention is before that. And so I think that some thought needs to be given into when you say prevention, then you have to include other situations where they're not in crisis, like going into the system. So definitely think you should explore that a little bit further. And I'm kind of going to come back and beat the drum again, even if I'm at the wrong point in the event. But what I see, I'm actually involved in a number of digital mental health groups. And what I see time and again is a focus on evidence-based, which means that they've been through a clinical trial. And that means that only companies that have been spun out of academia will have had funding to get a clinical trial. If you want to get innovative solutions that haven't been through a clinical trial yet, and so therefore can't confirm that they have met evidence-based, they can be evidence-informed, but they're not evidence-based yet because they haven't had that clinical trial data produced yet. These pilots are the opportunity for a number of organizations, myself included, to get more of that data. So it's kind of, you're almost kind of putting some companies, putting their hand behind their back and expecting them, or tying 2 feet together and expecting them to run a race. It's just, if you really want to get truly innovative stuff, on some level, you have to soften the requirements to be considered, but in the completing the program or getting the funding, have commitments to produce the data that shows the efficacy of the solution and the impact that's being made. But if you hamstring companies, you'll lose out on some of the real innovation happening.
Thank you so much, Katrina. Appreciate that. Okay. So Varani, you will be able to give your comment here now. You should be unmuted. And just to confirm, I've confirmed Mr. Hook, he would like to have his comments here captured for the record. You should be able to unmute. So Varani, can you try to unmute yourself now? Okay, I'm going to go ahead and move on, and I will try to assist you in getting unmuted. Gulshan, you are next commenter. You should be able to unmute your line now.
Hello, everyone. So Gulshan Yousafzai, I am with the Muslim American Society Social Services Foundation. Just wanted to mention about the second point you guys have as a proposed definition. However, you have the community-defined practices, the CDEPs, as part of that. I would really encourage uplifting and having that as a separate definition for the reason that I, as executive director of this agency and just in working in mental health for the last 21 years, I've been part of this effort for the last 10 plus years specifically. We have a CDEP that's part of the CRDP that because of this, we're able to serve refugees and immigrants from Arab and Afghan and Indian and Pakistani communities. And because of this effort and how innovative it's been, we are not only the only program or agency that does this in Sacramento, but in California. And to my knowledge, throughout the United States, including the first peer support program in the United States for refugees and immigrants. So just wanted to mention how effective it has been in terms of getting these communities who are generally from war-torn countries and various different languages. If you look at the Arab community, there's a good 20 to 22 countries. You look at the South Asian communities, I would say 5 to 10 plus, Afghanistan, Iran, many countries, India, Pakistan. You look at North African. All of these communities generally have historically been underserved and have a hard time accessing services and treatment and recovery support, specifically peer support. But with the program we've had under CEDA as a CEDAP in the past 10 years and moving forward, we've been able to serve these communities where they can actually trust and actually access services that are on all these languages. Thank you.
Thank you so much, Gulshan. Esty, your line should be open. You should be able to unmute yourself now.
Oh, thank you. Hello, everyone. Thank you for having me. My name is Esty Song. I'm with the SSG, APCTC, Asian Pacific Counseling and Treatment Centers. On behalf of Asian American Pacific Islander communities, I just wanted to share that we continue to face critical barrier in accessing mental health care due to deep-rooted cultural stigma and a lack of culturally and linguistically appropriate services. And I just wanted to highlight that prevention is so critical because through prevention programs that we could able to help reduce the stigma and raise more awareness so that the people who need a much needed service, they will be able to receive that services. I just wanted to share that recently, this past last week, 7th grader female girl, and she was having thoughts of suicide related to PTSD from bullying from her school. Her father initially resisted seeking help because due to the strong cultural stigma around mental health. But after several conversations and visiting, that he opened up and says, yes, my daughter needs help, so please help my daughter. So these are so critical. So I would like to understand that each communities are very different in their needs. And sometimes when we try to make it like, cookie cutter and everybody goes through the same. But if we, when we're doing innovation, I really hope that through innovation partnership funding, that we could able to really help people who are needed, regardless of their race and their ethnicity. So thank you so much for giving this opportunity. And I know that 90% of funding will go with the program, with the BISA new program, behavioral health. But with this innovation funding, I really hope that we could continue to do, I know it's only 10%, but so we could continue to do the intervention, the prevention work. So that way that we could help much needed help that our community members need. Thank you so much.
Thank you so much, Esty.
I just want to raise a comment in the chat about the instruction to unmute might not be understood by monolingual community members. And I'm wondering if we can give the interpreter instructions about unmuting.
Sure. We right now I'm speaking with interpreters, so hopefully that will be clear. I know we do have a comment, if people can bear with me, we do have a comment from Mrs. Hook. Although I will have to try to help unmute her. So if people would just be patient, I'm going to try to do that now. Let's see if I can. Oh, it might have worked. Let's see. No, unfortunately not. I'm sorry. I'll keep working with our interpreter and hopefully we can get that resolved. Thank you for your patience, everyone. That was our last comment at this point.
I feel like we have one more.
Kelly, we have one hand up. Or two hands up.
Ah, lovely. Thank you so much. Very long list to scroll through. Deb, your line should be unmuted. Go ahead, please.
Thank you, appreciate it. I apologize for not joining on a timely manner, so I look forward to hearing the recording. But I do want to express my concern and my desire to see us really look at as a whole what the definitions are of the services that we provide. You know, talking about prevention to me happens throughout our lifetime. I have 2 adult sons that are have serious mental illness, and prevention and for years I've dealt with both of them, and prevention is something that in recovery is cyclical. You know, we're good for a year or 2 and then suddenly we're not okay. And I think this idea that somehow it's linear and it's sequential and it doesn't go in circles or in fluctuations is a fallacy. And I think this idea that somehow all of us are impacted by prevention being in a certain spot or a limited capacity of prevention is being allowed is really problematic. So I question some of the definitions that have been utilized for this process and want to make sure that we can advocate as best we can to better serve our community with what's really happening in the life cycle of a person in recovery.
Thank you, Deb. Karen, you're our next commenter. Your line should be able to be unmuted now.
Thank you. This is similar to what I asked about earlier, but in a different way. So when the IPF, I assume there will be RFPs at some point when those are rolled out, that the target population eligibility for these projects will not be limited to what's on the list previously shared above in the above slide deck.
I say, Karen, are you talking about the mandate?
The WIC 5892.
Yeah, we have to comply with the law.
I think other people have shared, I guess, a confusing discrepancy that what type of prevention services or early intervention services, what would that look like if the target population eligibility is limited to those to that list?
Mm-hmm. Yeah, I mean, I know, so the mandate for the Innovation Partnership Fund in statute was exactly as we showed it. So that's what we have to comply with. I think there's good questions that are coming up here that, well, with early intervention, that is in statute. So I think that was already on the slide. So I think early intervention is clear that works in here. And in terms of prevention, it sounds like there's even in this conversation different definitions of what prevention is as it relates to the specified priority population. So I think we'll have to do a little more research on that. But I'm glad you mentioned that because I did want to clarify that early intervention is pretty clear that's there. It's the prevention piece that I don't think that's in the statute, or at least we'll have to find out if it relates. I think we need to do a little more research on that. So I'm glad people are raising it today because we need to make sure we're clear on all of that.
Thank you so much, Karen.
Thanks, Karen.
Our next comment is from Steve. Steve, your line should be unmuted. Go ahead.
Hi, thank you for allowing me to speak. I appreciate it. Within PEI, is there a classification that PEI can only be clinical? And is there any thinking around that idea?
I would say, what's your thinking, Steve? Do you have some ideas? it looks like you're on mute.
Go ahead and try to unmute yourself, Steve. There you go.
Oh, okay. Sorry about that.
No worries.
Within the idea of clinical only being available, and we had a person that was just speaking about how wellness is a journey, and I think of for veterans is that there's an opportunity to have arts as a practice, as a means to combat isolation, a way to stay in community, a form of avoiding participation avoidance, that it increases socialization and connectedness, and that is a form of our best type of wellness because we're engaged with people of our community. And that's what and when we speak of PEI only being available for clinical, that, you know, I haven't necessarily seen that happen for veterans. So I'm speaking of that idea.
Thank you so much, Steve. I do believe that is our last comment at this point.
Well, lots of great input and comments there. Thank you to everyone. We really appreciate it. We will move on in the presentation here. So we'll move on to the next slide, please. And one more slide. So we'll get into looking at the pillars. One more slide. All right. So the Innovation Partnership Fund would focus its initial, is there? Oh, there we go. It's a fancy slide. Investments on 3 strategic pillars. In alignment with the goals of the Program Advisory Committee. They're outlined on the slide here. So the first is youth prevention and early intervention at a population level. The second is workforce, expanding peer, traditional, and non-traditional providers to align with community needs. And the third is connection, enhancing quality and integration of behavioral health systems and services. So again, we're asking for feedback here with respect to the proposed pillars. We're interested in whether or not you all think these resonate with you, if you think something should be added, if something should be removed. I know Commissioner Tsai has joined us, and in the past he's shared some thoughts with respect to the pillars, so I hate to put him on the spot. I do this to him at every meeting. Are you there, Commissioner Tsai? Maybe not.
You're on
Okay.
mute. Oh, he is. Yeah,
Oh, he is there. Okay. I don't know if you have any comments with respect to the pillars today.
Yeah, thank you, Sarah. This is something that we've talked about in some of our prior meetings. It's consistent with some of the feedback that we've heard in prior commission meetings about important focus areas. I know that we just went through some of the priorities. I think that the intention of this is just to provide some parameters around our thinking with regard to IPF, specific to the importance of youth populations, workforce issues, which obviously impact all areas of behavioral health, and then really enhancing quality and integration of behavioral health systems and services. When we mention behavioral health here, we're specifically referring to mental health and substance use services. And so these pillars are intended to be broad. They're intended to encompass a lot of different focuses. And I think that's pretty much the key context that I would share before we start hearing folks' feedback.
Thank you, Chair Tsai. All right, so with that, we'll open it up for feedback from you all. We'd love to hear from you a little bit about what your thoughts are here with respect to the proposed pillars. As I said, well, hands are going up already, so we'll just open it up for feedback. Thanks so much.
Wonderful. Patrina, your line should be unmuted. Go ahead.
So this is my first listening session that I'm participating in, so I am coming up to speed quickly. But what I'm being struck by, trying to find the logic in all this, is priorities versus pillars. And I'm just wondering, as you refine this deck and present it, if there's like a cross matrix that explains how priorities and pillars interact. And that might help us, for those who might want to submit a proposal for this program, know how to frame it more effectively.
Patrina, I think you're asking a wonderful question or an excellent clarifying question. And certainly there will be a clarifying document in the future that will help to further provide detail to you all as to kind of how to specify how these things interact with each other for purposes of your proposal.
That'd be great. Thanks.
Thank you so much, Katrina. I'm gonna move to Josefina. Just a second. Your line should be unmuted. Go ahead.
Thank you so much. I had a similar question about trying to differentiate between the priorities and the pillars, and I don't know if the priorities are aspirational and the pillars are foundational. If that is the case, then I think that it's important to have some overlap between the priorities and the pillars, and so I would advocate to include a pillar that states community focused, are community driven, and also culturally responsive. In addition to that, I think that there needs to be a pillar that measures effectiveness. Again, like this is a big investment, and this particular innovation funding is very important, and it's a one of its kind funding, but there's no language here in any of the existing pillars that speaks to how we will measure effectiveness, how we will measure if what is funded is closing the gap in terms of what the priorities were stated. Like if this is supposed to be addressing disparities, then how do we know if what we're investing in is actually closing the disparities gap? So there should be a pillar here related to evaluation of effectiveness and how we will measure if we're reaching our priorities. Thank you.
Thank you so much, Josefina. Deb, your line is unmuted. Go ahead, please.
Thank you. I appreciate it. As I listened to all of the different folks sharing, I think one of the observations I have is we have done SIM mapping and mapping of our community and trying to find the gaps and looking at what can we do that will be innovative, that will improve our community's mental health services and fill some of these gaps. And I see that as what the innovation really is attempting to achieve. So I would like to see more collaborations potentially mentioned here. It's talked about briefly in the last bullet point here of enhancing quality and integration with behavioral systems and services. But as a recipient of a communication this week that our funding is going away for Mental Health Services Act because we were PEI, I find that our need to find the right fit for the things that we need to see happen are going to fall to these programs that you're opening up for us to consider. And I want to make sure that we're not missing filling those gaps or the gaps that are actually being created by the changes that were underway. So there's a lot of shifting, feels like a lot of shifting mechanisms and a lot of shifting priorities and shifting scheme of where we stand in our world, and how do we rethink our existence into a different way of being and helping our community. So I want to see our community improve, not diminish in their skills and then their access to services. And I fear that it's a little bit of shaky ground we're trying to operate in. So I just want to have more guidance. So I appreciate your listening.
Thank you so much, Deb. Carlene, your line should be unmuted. Go ahead, please.
Hi, yes, Carlene Davis, California Black Men's Health Project, also part of California Reducing Disparities. So one, I want to also lift up, I think, the importance of cultural responsiveness, and also having had prior demonstrated experience working in BIPOC communities is very important. I just have a question here because youth is here as a pillar. However, previously in the populations, you had youth and then you had adults and older adults. And so I'm not clear then why only youth is lifted up as a pillar. And then in terms of workforce, um, I think what's important in how this ultimately gets defined is that, um, particularly with the non-traditional providers, that non-traditional providers can serve also non-Medi-Cal populations because the Medi-Cal eligibility is beyond destitution in the state of California. And so if there's someone in need who makes like whatever the threshold of share of cost is, but is still in high need, but these pathways get defined as by serving Medi-Cal populations, then that is going to create another level of disparity.
Thank you so much, Carlene. Appreciate you. And Karoff, your line is unmuted. Please go ahead.
Real quick, Kelly, I see Commissioner Sai has his hand up.
Oh, well then Commissioner Sai, give me just 1 second. Just 1 moment, please. Commissioner Sai,
Yeah, thank you,
should
Kelly.
be
Thank
able
you,
to unmute
Sarah.
yourself. Yeah,
Thank
go
you.
ahead.
Just a quick response to the last comment. Thank you. And that did come up in prior groups. Just wanted to highlight that the mention of youth for pillars isn't meant to exclude other groups, right? And so earlier when I mentioned that for the connection bullet, the third bullet where it talks about enhancing quality and integration of behavioral health systems and services, that would be inclusive of all populations. The reason why we wanted to specifically highlight youth here is because we wanted to recognize that sometimes youth can be overlooked when we're prioritizing a number of different needs. And we wanted to specifically lift up youth because obviously if we do well with youth, which is kind of represents upstream populations, that can result in downstream benefits, right? Basically later on in their life. And so that's the reason why it's mentioned here. So similar to a prior comment, there is some duplication or overlap between what's included in the pillars and in the priorities for that reason. So thank you.
Thank you for that, Commissioner Sai. Okay, back to you, Ann Karoff. You should have your line unmuted now. Thank you.
Hello.
Hello. Go ahead, please.
My name is Ankirat Plip. I am come from Sahakom or Cambodia family. Yeah, today I have some, like to share all the people in this room because I'm from the Sahakom. Okay. ខ្ញុំចង់និយាយថានៅក្នុងសហគមន៍ខ្មែររបស់ខ្ញុំមានប្រជាជននៅក្នុងសហគមន៍ជាច្រើនដែលមានបញ្ហាសុខភាពផ្លូវចិត្តហើយដោយសារពួកយើងមានវប្បធម៌មួយដែលយើងមានជំនឿនិងមានវប្បធម៌មួយដែលមានព្រះសង្ឃអាចជួយជាជំនួយចិត្តដល់ពួកយើងក្នុងការប្រោះព្រំជាអនុវត្តជាការប្រោះព្រំក្នុងការព្យាបាលផ្លូវចិត្ត
Sorry, do we have a translator, a Cambodian translator on?
We do. Our Cambodian guests are choosing to speak for the record.
Oh, okay. Great.
Thank you. And Karoff, you can go ahead, please.
So, I don't hear any people translate for me.
You won't hear them right now. I can put you back in the translation room when you're done giving your comment, but you won't be able to hear them while you're giving your comment.
Okay. Thank you.
Thank you so much.
Okay. ចាអញ្ចឹងម្ដងទៀតខ្ញុំគ្រាន់តែមានសំណូមពរមួយសម្រាប់សហគមន៍ខ្មែររបស់ខ្ញុំដោយសារសហគមន៍ខ្មែររបស់ខ្ញុំមានវប្បធម៌មួយដែលយើងមានទំនុកចិត្តទៅលើព្រះសង្ឃដែលអាចជួយប្រោះព្រំពួកសហគមន៍យើងខ្ញុំជាជំនឿមួយនៅក្នុងសហគមន៍ដែលជួយឲ្យផ្លូវចិត្តពួកយើងនៅក្នុងគ្រួសារពួកយើងនឹងអាចផ្ដល់នូវភាពស្ងប់ស្ងាត់និងតភ្ជាប់នឹងអត្តន័យជាកត្តាការពារផ្លូវចិត្តជាពិសេសសម្រាប់មនុស្សចាស់អ្នកភៀសខ្លួននិងសហគមន៍ជំនាន់ទី1និងទី2ដែលកំពុងទ្រាំទ្រនឹងភាពតានតឹងនិងក្តីព្រួយបារម្ភនិងរបួសផ្លូវចិត្តការផ្ដល់ថវិកាសម្រាប់ការអនុវត្តទាំងនេះគឺជាការវិនិយោគផ្នែកសមត្ថភាពដែលធ្វើឲ្យមានសេវាថែទាំកាន់តែងាយស្រួលនិងមានប្រសិទ្ធភាពសម្រាប់សហគមន៍យើងខ្ញុំអរគុណច្រើនចា៎
Thank you so much. We will go to our next comment now, which is with Shanti. You should be unmuted or able to mute yourself. Go ahead, please.
Hello, thank you. Wanted to apologize. I'm recovering from a cold, so sorry if I take a second to cough in between words here. Shanti Ezrin, I'm with the California Association of Marriage and Family Therapists. We represent over 39,000 MFTs across the state, and I wanted to start just by thanking everybody involved at the commission for including workforce as one of the highlighted pillars here. I've been listening to this session. I was in the previous session as well and provided some comment. And any and all of the projects in terms of service delivery that I've heard requires a qualified workforce that meets the service demand. And I think we've all taken a look at a bunch of different studies around the behavioral health workforce over the last however many years. And we can see very clearly that we're facing a significant behavioral health workforce shortage. So when we talk about innovation and we talk about this funding, I think it only makes sense for funding to support our providers in an area where they are currently not well supported. And that area that they're not well supported is really in that pipeline where they're working in practicum as qualified service providers. Gaining their hours to become registered associates and then onwards to hopefully licensure. These are recognized providers, at least under specialty mental health, working in public systems where we really want them to be working in and really need them to be working in, serving all the individuals that were defined earlier in this meeting as priority populations. But the current model for trainees and practicum sites really makes it difficult for them to support themselves financially. And what we see is early burnout. We see folks falling out and not continuing on to licensure. So I really think any project that would partner with graduate programs to support more paid practicum sites would meet that definition of innovative, because it's really shifting that graduate program practicum system, from what is seen as a training as an education requirement to a training as a service delivery investment in those individuals that are working, like I said, towards licensure and hopefully remaining in those public sites serving these populations that we've been talking about today. So I'm happy to follow up with a written letter to the committee that is going to be leading this effort. I heard that that is going to be on the 18th of this month. So happy to submit a letter and make myself available for additional follow-up and information. Thank you.
Thank you so much. I believe those are our last comments in this area. Thank you.
All right.
Oh, it looks like
We actually have one more that, where'd it go? I think I saw for a second. Was that Laurel? Okay, just one moment, Laurel. You are unmuted at this.
Hello, where am I? Can you see me? Yes, no?
Yes, we can see and hear you,
All right.
Laurel. Hello. Welcome.
All right, so I've attended all of these listening sessions, so I should let you know. And I'm going to go back a little bit to what I've said back when I was thinking about the pillars, and that the pillars, what are the pillars? Well, the pillars are what support the building, the innovation building, and the improvement of the mental health system. And we can tell if something is a pillar because if we remove it or we fail to include it, the building will collapse. That's how important pillars are. So they're not afterthoughts. They're not a little, little there. They need to be really well thought out. All right. And so I wanted to say that I brought up before that I think using youth as the pillar is the wrong direction. You should say families or youth in families, because if you exclude families or neglect them, that will come back to bite you later because of the nature of our state, in which individualism is less important for many populations than collective membership and support within the family or the extended family, even the clan. So I'd like to reemphasize that. And I know that you have heard a lot of comments, and for some things you've changed. For example, you have a slide that shows a lot of, I call them floating words that have been, and concepts that have been brought up in previous meetings. And you did add in CDEPs up in the upper right-hand corner. Yay, I'm so happy for that. All right. But you haven't added in family anywhere. And I'm asking for that and hoping maybe some other people will ask for that as well. So I wondered if this might have to do with a lot of Proposition 1 being the creation of the governor and his team, and youth was very, very important. There was the California CYBHI, California Youth Behavioral Health Initiative, which acknowledged the importance that the kids are not okay, but it sunsets. And I wonder if you're maybe hesitant to say family because you don't want to abandon youth, since maybe that some of those projects may get funded through this. But I would say then youth in family, youth in the environment of their families. I wanted to back up, support what Josefina said about culture. Not quite sure how it would fit, but it seems to me that neglecting culture as a pillar could lead to collapse. And I think we all know of programs and projects that have collapsed because not enough attention has been placed on cultural appropriateness, culturally and linguistically appropriate services. Culture and language are just so important. So I would like to again say that I'm with Josefina in asking you to consider culture in some form as a new pillar. Thank you.
Thank you so much, Laurel. Oh, go ahead.
I forgot to introduce myself. Oh, I'm Laurel Ben-Hamida with Muslim American Society Social Services Foundation and REMCO, the Reducing Mental Health Disparities Coalition. Thank you for your patience.
Thank
And
you
real
so
quick,
much.
before we pop over to Ellen Kelly, I was just gonna say to Laurel that we updated the background slides, but we're trying to keep the actual question slides the same so that we're asking everybody the same information. So we haven't evolved, it's just the same information being, same questions and information being shown, unless there was an accuracy issue. So, but otherwise, Laurel, that's why you saw the changes on background stuff, but not on the thing. So, but we're capturing all the input through all these sessions for that. So thank you. And good to always reiterate it and see what people are saying about that as well. So thank you.
while I'm at it, please post the recordings of the previous sessions. I think there are a lot of people, not just in California, but far, far from California, who would like to know more about how this process has worked.
Thank you, Laurel. Going to move to Alan. Your line should be unmuted.
Thank you. And to weigh in what Laurel mentioned about the youth, as I'm looking again to the target populations for the new act, I can see that the youth pillar states early intervention, and usually that's defined as from newborn to maybe age 5 or so, very, very early on in life. As I'm going through the target population, we can see where it might be eligible for chronically homeless or experiencing homelessness. Maybe, they're at that young age and they're experiencing that. At risk of being in the juvenile system or justice system, maybe they can be at risk if one of their parents have been in that system before. Automatically it would put them at risk, or any other caretakers. Re-entering the community from youth correctional facility, I'm not too sure that that does not apply for the children early on in life, are in welfare systems or at risk of institutionalization. So maybe just looking into those definitions and seeing if prevention and early intervention is even possible through this new law and the target population that this law states.
Thank you so much, Alan. I believe that was our last comment on this section at this time.
Thanks, Callie, and thanks to everyone for your input on the pillars. We appreciate it. All right, so I think our next section is just a reflection on the timeline. As you heard, our upcoming PAC meeting is on the September 18th. So that will be our next presentation of the revised materials. And then following that, as Melissa laid out earlier, we'll have the commission meeting in October. Next slide, please. Then just wanted to open it up for general feedback opportunity. Anything and all, we take any and all. Anything else that you may not have had the opportunity to speak on today?
If you'd like to make a general feedback, to remind you to raise your hand at this time. This will be the last opportunity today for feedback. Okay, I'm going to go ahead and start with Tanya. Tanya, your line should be unmuted.
Hi. I just wanted to thank you for letting me listen to all you guys today. I'm excited to see what you guys come up with for new opportunities. I have a mentally ill son, and there's a lot of need out there for qualified mental health clinicians working in the engaging in the community. And I would like to share one story about my son going to clinics and doctor's offices and trying to get medication. It's a long process. And then when you're going to a clinic to get a refill, like my son was on Invega shots. And that was the one big thing he didn't want to do, because he didn't want to spend all day in a clinic and then get to the end to where it's his appointment and they didn't have his medication. And I just wanted to share that, I don't know who put this together, but they allow pharmacists to give injections now. And I just wanted to share that information and hope that maybe other clinics, might share that with their clients, their patients, because it did make a difference. Very quick appointment, go in, shot, and you're out. And I think it made compliance a lot easier. And then just one more thing about the funnel. Somebody mentioned the funnel. The funnel is really clogged and everybody seems to be going in the same funnel. I would just love to see a flow chart where we can kind of look at what services are needed for, because everybody's individual, and maybe we can free up that funnel a little bit. Thank you.
Thanks for
Thank you so
sharing,
much,
Tanya.
Tanya.
Yep.
I believe Tanya was our last comment for the night.
All right. Well, thanks again to everyone for participating today. We really appreciated everybody's feedback, input, dialogue, all of the above. Looking forward to the next meeting, the PAC meeting on September 18th for next opportunity for review of materials and input into any discussion. Thanks so much and have a lovely evening, everybody.
Thank you, everybody, for coming.